Welcome and thank you for joining Seyfarth's webinar, Half an Hour for Healthcare, Part 3, New Minimum Wage Law, Where Are They Now? All participants are in listen-only mode. You are encouraged to submit questions throughout the program throughout the Q&A section located on the right-hand side of your WebEx window. Any unanswered questions will be followed up by email after the webinar. For those interested in a CLE credit, an attendance verification code will be read during the presentation. Please write this code down. It will not be repeated and is required for a CLE credit. Copies of the webinar recording and materials will be distributed to attendees in the days following the webinar. On the next slide, you will see a legal disclaimer. This presentation has been prepared by Seyfarth Shaw for informational purposes only. The material discussed during the webinar should not be construed as legal advice or a legal opinion on any specific facts or circumstances. The content is intended for general information purposes only, and you are urged to consult a lawyer concerning your own situation and any specific legal questions you may have. At this time, I'd like to turn over the program to Par. You may begin.
Hi, everybody. Thank you so much for joining us today. My name is Par Vafainia. I'm an associate in Seyfarth's San Francisco office, and I'm joined today by my colleague, Brian Gillis, who's also an associate in our San Francisco office. And we're very excited to be talking to you all today about the new healthcare minimum wage law. Next slide, please. So some of you may know this. We did a presentation on this law last year before it went into effect. And we thought it would be prudent to kind of circle back now that it has gone into effect because, you know, at the time it was first implemented and before it was implemented, there wasn't a lot of guidance from the state about, you know, the reach of the law and what certain, I guess, requirements within the law really mean. So we wanted to kind of go through the law again with you, give you some background and scope of the law, run through the minimum wage obligations, and run through the considerations that employers should have in mind, this time with the benefit of the added guidance provided by the DLSE. So with that, we can move on to the next slide, and I will hand it over to my colleague Brian to go over some background.
Thanks, Par, and we can jump into the next slide too. So yeah, we've been hearing about this bill for a while. It was passed almost 2 years ago, and we know that it created different wage schedules depending on the type of facility or employer you are. And it was supposed to be initially implemented in the last summer of 2024, but there was a delay. The state actually realized that it might not itself have the budget to implement the increases right away. So they implemented a second law that delayed the effect until the state was ready. They had a couple of thresholds they needed to reach. All that said, it did finally go into effect October 16th, 2024. So for all of us that are covered, we're in the sort of first phase, the first schedule of this increase, which we'll talk about more later. In fact, yeah, many of the facilities impacted are looking at hitting the next phase, the next schedule very soon in a couple weeks. So yeah, we'll talk about that in a bit. We can go to the next slide, and I'll pass it back to Par to kind of talk about who is covered and what the different considerations are there.
Thanks, Brian. So this is an area where, for those of you who remember looking at this law when it was first passed, it's very much centered around, you know, what it is to be a healthcare facility, right? Because the who is covered is the covered healthcare facilities. And when I first read the law, it was very much in legalese, right? Like if you operate a facility covered by this section of the code. Now we have much more clarity and a much simpler way, I guess, of looking at what is a covered healthcare facility, right? And so what we've done, as you can see on your screen, is we've broken it down into basically 4 buckets. The hospitals that are covered, the home healthcare, you know, in the residential setting, those that are covered, physician groups that are covered, and then, you know, this catch-all other covered facilities. And I'm not gonna, bore you all by reading what you have on your screen, but it is very nice to have this additional guidance from the DLC that makes it very simple to see, are we covered or not? Do we fall within this or no? One thing you'll see though, so for the home health care, you'll notice that, skilled nursing facilities are listed, but only certain skilled nursing facilities are covered, specifically those that are owned and operated by a hospital or an integrated healthcare delivery system. And we'll be going over what an integrated healthcare delivery system is, and talking about what little additional guidance the state has provided on that front. But before we move on, one point I wanted to add on the background is, as Brian mentioned, there was a delay in the passage of the law, and that resulted in a few amendments. So when we first got the bill, it was codified in it was going to be codified in sections 1182.14 and 1182.15 of the labor code. They later added 1182.16. So just an interesting tidbit. And with that, we can move on to the next slide and talk about integrated healthcare delivery systems. So when we talk about the different minimum wage schedules, you'll see kind of the importance of what it is to be an integrated healthcare delivery system. It is a really vague and broad term. There's some good news and some bad news. The good news is that if you are a part of an integrated healthcare delivery system that employs 10,000 or more full-time equivalent employees, you don't have to wonder if you are an integrated healthcare delivery system, because the government has published a list of all of the integrated healthcare delivery systems with 10,000 or more full-time equivalent employees. But that still means that, there are other systems that theoretically have less than 10,000 full-time equivalent employees that aren't, listed somewhere. And, so for those types of employers, we need to look at, okay, are we an integrated healthcare delivery system? And at a high level, as you'll see on your screen, an integrated healthcare delivery system is defined to include, a system in which there includes one or more hospitals and then one or more related entities, such as a physician group, a healthcare service plan, medical foundation clinics, or another healthcare facility, or an organization that either provides healthcare or supports healthcare delivery. So again, quite broad and quite vague. So we can move on to the next slide. Because there is a little bit of clarity. I mean, they, what you see on your screen right now is basically what is in the original iteration of the minimum wage law, but it's basically how the DLSC has simplified it and put it in more simple terms, I guess. So in order to be considered an integrated healthcare delivery system, there has to be some sort of a connection, right? And there are, generally speaking, three different types of connections that we want to look out for. One is in a connection in ownership or management. So in that regard, we're looking for entities that are related through a parent subsidiary relationship, or that have a joint or common ownership or control, or that share branding or use the same trade name, or they have common boards of directors or shared senior leadership. So that, I think, is a pretty concise and helpful definition of what we need to look out for in terms of an ownership or management link. Separately, a connection could be through a contractual relationship with common branding. So there's a contract between the two different entities, or multiple entities, for example, or it could be a physician group. So for example, a physician group contract with a hospital or with a health plan. And then there's this added requirement that they operate under a common trade name. So looking for branding again. And then the third bucket of connection to look out for is, a nonprofit health plan with exclusive regional physician groups. So honestly, I was hoping for more clarity from the DLSC on what it is to be an integrated healthcare delivery system. And frankly, it would have been helpful for them to give more examples, because I will say, in some regards, I think you can clearly figure it out. In others, I think it's a little bit more ambiguous. But for now, the only guidance they've provided is what you see on your screen. So we will, of course, keep an eye out for any additional developments on this front. But that is where we stand in terms of what an integrated healthcare delivery system is. And with that, we can move on to the next slide.
All right, so now we'll talk about, so, we have who's covered from at a facility level, and now we're going to be talking about, who's covered in terms of at the employee level. So for an employee to be eligible for the increased minimum wage, they have to work for a covered facility and be a covered employee. So this is very broad, but to qualify, you need to be considered working as a healthcare service or services in support of the provision of healthcare. So yeah, very broad, covers a broad scope of employees at a facility. In terms of healthcare services, that's what we traditionally think of: nurses, the caregivers, interns, medical residents, etc. But also included are those that support the healthcare delivery. And so this brings in all of the ancillary services: janitors, housekeepers, the facility groundskeepers, security guards, business office staff, the call center workers, people working on billing. It's a long list, and generally it's broadly defined to include a large scope of employees that are supporting that provision of healthcare services. So yeah, and so we can jump to the next slide. So we'll kind of get into some specifics here. It gets a little more complicated when we're looking at employees that are contractors or working with contractors or subcontractors. An employee that's employed by a contractor is still covered if they are performing healthcare services that support services, and their employer, the contractor, has a contract with the covered facility to provide those services, and then also that the facility is considered a joint employer, and that has its own legal meaning, but basically, it comes down to whether the facility has control over the workers' hours and pay and job functions, or the worker spends more than 50% of their time in a work week physically working at the covered facility. Okay, so I'm sure that's very clear now, but we'll talk about it with a specific example. So if a contractor has an employee who does, let's say, off-site laundry for a covered facility, and the worker is working 100% for the work they're doing is 100% for the hospital, the worker would not be covered as long as the hospital is not considered a joint employer, because the worker is not on site working 50% or more of the time. So hopefully that's a little bit clearer, but we do have to sort of do this 50% analysis for any employees that are working for contractors or subcontractors. We'll talk about another example here. So let's jump to the next slide. So if there's a janitor, let's say, who's working both at a healthcare facility and also working at a non-healthcare facility, they would be covered if they spend more than 50% of their work week at the covered facility. And then that means that during that time, for the hours worked at that site, they must be paid the healthcare minimum wage. But if they spend less than 50% working at the covered facility, then they're only eligible for that higher minimum wage if the healthcare facility can be considered legally their joint employer. And I don't know if we'll have any public employers here, but their rule is a little bit different for public employers. For a public employee that's working at a covered facility, if they're working more than 50%, then all of their hours worked, not just the hours worked at the site, need to be paid at that higher minimum wage. But again, that's just for public employers. Okay, so now I'll pass it back to Par, and she'll cover some of the details with the actual wage schedules.
Thank you so much, Brian. And we can go on to the next slide. But one thing I will note is I was actually happy to see the guidance from the DLC as to, who is with respect to the contracted employees, who is and is not covered. That was very helpful in one area where they gave a lot of substantive guidance. So that was really nice to see. So now we're gonna switch gears and talk about the minimum wage obligations. And before we get into the various schedules, I'll just flag that if you look at the DLC's website, they have a very helpful chart that basically, I think it breaks it down into like eight parts of what minimum wage schedule applies based on the type of facility you are, the size of the facility you are, and like whether or not you're tied to the government essentially. So to simplify that though, we've kind of broken it down into four different schedules because it can be simplified that way. And the four schedules you're going to see again, it's taking into consideration the size and the financial capabilities of the employer, the type of facility and the services provided, and then geographic and demographic realities. So looking at Schedule 1, which is on your screens, you'll see that this applies. This is kind of the one on the upper end of the rates you'll see, because this is the one that applies to hospitals and integrated healthcare delivery systems that have 10,000 or more full-time equivalent employees. But it also applies to skilled nursing facilities that are operated by these large systems, and then dialysis clinics and healthcare facilities run by large counties. So again, like based on size, right? And you'll see that wage schedule on the right-hand side of your screen. One thing we want to flag is those entities you see listed on the left side. Different start dates applied depending on the type of entity. So specifically, the healthcare facilities run by large counties, the law didn't go into effect until January 1st of this year. Whereas for every other entity you see listed on the left-hand side of your screen, the law went into effect in October of 2024. So just a small thing to flag. And you'll see the wage schedule and how these rates are set to increase. And as Brian mentioned earlier, you can expect to see the next round of increases will be July 1st of 2025. So that's actually right upon us. I was actually quite surprised to see that although they had pushed back implementation of the law to October, I was surprised to see that they didn't also change the schedule so that it, is every year. So it's less than a year at the original rate, and now we're moving up. So with that, we can move on to Schedule 2 on the next slide. And this one, it applies to safety net hospitals and facilities run by small counties. And you'll see the wage rates on the right-hand side. This one's interesting because it's based on percentages. It's not quite as straightforward and set in stone as the other schedules that we'll look at together. And this is another situation where, the county facilities had a different start date in terms of when the law went into effect. It was January 1st of this year, whereas for the safety net hospitals, it was October of last year. So with that, we can move to Schedule 3. And I should have mentioned what qualifies as a safety net hospital. We'll cover that later. So that's coming up. But in the meantime, so Schedule 3, this one applies to intermittent clinics, community clinics, rural health clinics, and urgent care clinics associated with community/rural health clinics. This one, there is no exception to the wage schedule you'll see on the right-hand side. It went into effect for all of these entities back in October of 2024, started at $21 an hour. This one, however, the rate increase will not happen until 2026, July of 2026, so not this year. And that'll be a $1 bump, but then a more significant bump in 2027, up to $25 an hour. So, and then further increases will come in 2029. So this is a little bit less aggressive, I guess, in terms of how quickly we're going up in the rates. With that, we can move on to Schedule 4. And so this is kind of like a catch-all. So all other covered healthcare facilities that are not listed in the prior categories and not run by counties would be covered by this. There's an asterisk there you'll see because there's a caveat for skilled nursing facilities. So as we previously discussed, skilled nursing facilities that are tied to integrated healthcare delivery systems or hospitals with 10,000 or more full-time equivalent employees fall under Schedule 1 that we've already covered. But what about the other skilled nursing facilities? For those, those that are not covered by Schedule 1 would be covered under Schedule 4 is what I mean to say. but that only takes effect if a separate patient care minimum spending requirement is passed. So that's the caveat that we wanted to flag with respect to skilled nursing facilities. And then the other category of entities covered by this schedule would be facilities run by medium-sized counties. So population of between 250,000 and 5 million. As with the other wage schedules, the county entities had a different start date as to when this law went into effect. It went into effect in January of this year. Everybody else that you see listed, the law went into effect in October of 2024. So that's the four basic buckets that we've broken this into in terms of what are the minimum wage rates that apply depending on what kind of entity you are. With that, I will go ahead and pass it back to Brian.
So we can go to the next slide, and yeah, we'll just touch on a couple of the nuances related to the wage schedules that Par just went through. And then first, just Par mentioned safety net hospitals, which follows that second schedule, a slightly lower initial minimum wage than Schedule 1. And to qualify as a safety net hospital, a facility must fall into one of these categories. Essentially, it's either generally a hospital, which is all the hospitals with a high governmental payer mix, and that's just 90% or more of the patients are covered by Medicare or Medi-Cal. But if you are an independent hospital, so a subset of that group, you only need to have an elevated payer mix. So that's that 75% threshold of patients on Medicare or Medi-Cal. And that just means that you're an independent hospital. You're not part of a larger hospital system. And then also rural and independent covered healthcare facilities are also considered safety net hospitals. Thankfully, the Department of Healthcare and Access and Administration or Information has been maintaining a public list of these designations. And I think we have we'll show you where to access that later, but that list is available to see whether your facility may fall into one of these safety net hospital categories. And we can jump to the next slide, talk about a couple more nuances here. And we're talking, okay, so yeah, mental health workers generally are covered, but only if they work for covered facilities. And so basically what we're flagging here is that mental health services are considered healthcare services. So an employee that is providing these services for a covered facility is going to be included in that requirement for the higher minimum wage. And so those are covered facilities that may be providing mental health services would be, on this list below here. But just as a quick sort of example, so if you have a therapist who's working for a covered hospital, that person would be entitled to the healthcare minimum wage that's applicable to that facility. But that same therapist, if that therapist is working for a private practice facility or a nonprofit clinic that's not covered, then obviously that employee would not be entitled to that higher healthcare minimum wage schedule. So we can jump to the next slide here, and we can move on through. So we'll just discuss a few more considerations for all the employers as we're rolling out these phased increases. And then the first to note and highlight, just to kind of clarify the impact that the higher minimum wage has on the categorization of exempt salaried employees. It's important to note that to continue to be properly categorized as exempt, the employee must earn a salary that's 1.5 times the new minimum wage for the healthcare minimum wage, or two times, or the normal 2 times the state minimum wage. And the importance here is just noting that there could be situations where the healthcare minimum wage multiplied by 1.5 is actually is higher than what the local standard minimum wage would be. And so you just need to be careful about making sure that you're not inadvertently misclassifying exempt employees because these healthcare minimum wages are getting a little bit higher and higher with that 1.5 multiplier. So that's an important to look for, especially as these phases get rolled out with the higher wages coming soon. And then the other quick note, just this does not impact any of the sort of deductions that you can make for meal or lodging credits with regards to the minimum wage. The same IWC limits will still apply there, and so this doesn't impact the credits that you're allowed to offer employees to meet that minimum wage threshold. Okay, and so Par, I think now is going to discuss some more considerations that we should be thinking about as these phases get rolled out. So I'll pass it back to her.
Thanks, Brian. We can go on to the next slide. So one key, factor that I think it's very important to have in mind, and this isn't really from the DLC guidance, it's just what we've known since this law, the bill was first introduced, and that is that we need to be mindful of how it impacts our collective bargaining agreements, because as many of you know, there are certain exemptions under the labor code that apply if there's a collective bargaining agreement in place. However, those exemptions will only apply if, the employees covered by the CBA are making at least 130% of the minimum wage. And so, that used to be the general minimum wage, and now it is the healthcare minimum wage, because that's the applicable minimum wage. So as, collective bargaining agreements are being renegotiated as they lapse, we want to be mindful of making sure that whatever rates are set forth are 130% of this new healthcare minimum wage. And also be mindful as we do that about the increases that we're going to see going into effect. So we just wanted to flag that. And another consideration, which, it is likely not going to be impactful for many of you, but may help some. There's this waiver program that's part of, that's embedded into the law, and that is meant to help, give additional time to come into compliance. So in essence, those that applied for the waiver program, and the application period actually ended back in 2024, but those that applied and were accepted, for them, compliance would be delayed by a year, and then the increases would also be delayed by a year. So there is the existence of that program within the law. And with that, we can go to the next slide. Another big consideration to keep in mind is the notice requirements. So that lovely screenshot that you see on the right-hand side is the poster that has to be posted. It's actually just page 1 of it. Page 1 says what the rates are that are in effect right now. I believe page 2 of the notice goes over the increases that we will see go into effect. But this notice has to be posted. In addition, employers must provide written notification to their employees, outlining the schedule that applies to them in the increases. And then there are additional requirements, as you will see on your screen, for waiver recipients in terms of notification. Specifically, they must post the waiver in a conspicuous location within 10 days of its effect, and then they have to provide notice to each covered healthcare worker stating the waiver was received and listing the applicable delayed minimum wage rates. So with that, we can go to the next slide. So other considerations, remedies. One bit of clarity we got from the DLSC is that, there's a frequently asked question that says, okay, so what if my employer tells me that I'm not covered by a particular schedule or by the law at all? I'm not a covered healthcare employee. The DLC's response to that was, well, it's on your employer to show that you are not entitled to the healthcare minimum wage. So that's something that we want to be mindful of course, because they're kind of putting the onus on employers. And also the DLC clarifies what kind of action an employee can take if they believe they are not that they are owed minimum wages under this minimum wage law that they haven't been provided. And in essence, that is, you can file a claim with the DLSC, you can file a report of labor law violation, and you can file a lawsuit or bring an arbitration demand. And that's consistent with what we saw in the law when it was initially passed. So with that, I will turn it back to Brian to talk about preemption issues.
Thanks, Par, and we can go to the next slide. We just have a minute here, so we'll be brief. But we knew this, but we've confirmed local ordinances cannot be passed that set a higher healthcare minimum wage for healthcare workers. But that doesn't mean that a local minimum wage ordinance that's generally applicable is prohibited. That is allowed. So a local minimum wage that is generally applicable that sets a higher minimum wage above what the healthcare worker minimum wage is allowed. It's just that cities and counties can't pass healthcare specific requirements for minimum wages. And then we'll jump to the next slide. And this is just noting what we had talked about earlier, that the state has been keeping lists of these facilities with 10,000 or more full-time employees, as well as the lists of the safety net hospitals. So you can find that on the DIR's website. And with that, I saw a couple of questions come in, but cognizant of everyone's time, so I think we will conclude this session, and we can follow up via email with those questions. So thanks for sending those in. Just wanted to highlight we will be having another half hour for healthcare session this fall in September. Topic TBD, but stay tuned for that announcement. And with that, we can move on to the CLE code on the next page. The code for this session is SS6443, SS6443. And you can use your phone to hopefully scan this QR code to complete the Seyfarth form to get that verification form submitted. Thank you all so much for joining us today, this morning, this afternoon, and appreciate your time. And here's our information if you have any further questions.
Thank you all.